So it's 3 minutes past the hour, and I think would like to start. Um, so this is a webinar on learning agenda on hepatitis B birth dose vaccine delivery in Africa, insights and recommendations to improve timely administration. Very good morning, good afternoon, and good evening, everyone. Next slide, please. So on behalf of the organizers, which is PATH in partnership with Gavi, I would like to take this opportunity to warmly welcome all of you to today's webinar. This is a very timely and important discussion, and we are so glad to have you join us. My name is Dr. Albert Komba, and I'm the director of Safe Start Plus project. This is a 4-year initiative that is funded by Unitaid, and it's led by PATH, the International Community of Women Living with HIV in East Africa, ICWA, and also the World Hepatitis Alliance, WHA. So Safe Start Plus project is working with countries and communities to ensure that mothers receive high quality, integrated, and people-centered antenatal screening and treatment, and that babies are protected from preventable vertically transmitted infections, namely HIV, hepatitis B, syphilis, and Chagas disease. So over the past year, PATH's hepatitis B birth dose learning agenda, which has been supported by Gavi, also in partnership with Unitaid, has generated valuable evidence that is directly informing the Safe Start Plus scope and strategies. This work helps us to understand how to strengthen timely hepatitis B birth dose delivery for babies who are born both in facilities and out of facilities. So today I'm very eager to hear about the learning agenda findings and innovative approaches emerging from this work. We are very privileged today to be joined by a diverse panel of government leaders, immunization and primary healthcare experts, but also civil society partners and researchers representing Ethiopia, Uganda, Nigeria, and the Gambia. So again, thank you very much for all of you joining this session and contributing your experience to these insights. We have an agenda today, which is going to be shown in the next slide, basically sort of broken into 3 parts. We'll start with the first part. We'll be hearing remarks from Unitaid and Gavi. So from Unitaid, eliminating vertical transmission and the Safe Start Plus platform. And then from Gavi, you'll be hearing an overview of the global progress on scaling hepatitis B birth dose. And then I'll invite a colleague from PATH who will be setting the scene, presenting on hepatitis B birth dose learning agenda, insights from the cross-country synthesis. And then we'll have a wonderful panel who will be sharing some reflections on learning agenda insights to inform coverage of hepatitis B birth dose, including out of facilities. We're going to be having an interactive Q&A session that will be run by one of my colleagues, and I'll be introducing that. And then later on, we'll end up with the closing remarks. So very quick announcements before we begin. Number one, I would really appreciate if you can share on the chat screen your name, your organization, and country. That would be very great. But also, we're going to have a Q&A session at the end. But in the course of presentations and discussions, please feel free to submit your questions on the QA box at any time. We'll be collecting those questions and we'll respond to them during the session that will come later on. And again, this webinar is being recorded and we shall be sharing the recording. Next slide, please. So without any further ado, we're going to start with the 2 sessions. These are remarks. The first session of the remarks will be given by Kelsey Barrett. She's the technical manager, maternal newborn health strategy at Unitaid. And she's going to be giving us some remarks on eliminating vertical transmission and the Safe Start Plus platform that I briefly highlighted. So the stage is yours, Kelsey. So.
Thank you, Albert. It's a privilege to speak to the importance of eliminating vertical transmission and Unitaid's work with PATH and Gavi and partners in this area. So as you know, every year, millions of pregnant women are affected by HIV, syphilis, hepatitis B, and Chagas, conditions that are preventable, treatable, and yet still vertically transmitted to babies at alarming rates. So without timely screening and care, these infections lead to more than 1 million cases of avoidable illness, disability, or death among newborns annually, including stillbirths and lifelong chronic disease. This burden is not inevitable. We know that it's a very solvable problem and one that demands our collective commitment, innovation, and investment. So this is why Unitaid invested in eliminating vertical transmission, or EVT, and the Safe Start Plus initiative, as Albert's introduced. This initiative is led by PATH and a consortium of partners to integrate high-quality, people-centered services for EVT into antenatal and newborn care platforms across countries with the highest burden. Eliminating vertical transmission requires more than individual interventions. It requires integration. So that's bringing screening, diagnosis, treatment, and vaccination together into a single coherent platform that meets women and newborns where they are. Safe Start Plus embodies this vision. It's a 4-year, $22 million initiative to support country and community leadership to scale up integrated EVT platforms, addressing specific barriers to scale up with evidence generation and market shaping interventions, and advancing regional policy and learning to further increase adoption and access to essential EVT products and services. And this work is already underway in 9 countries across Sub-Saharan Africa, Southeast Asia, and Latin America. And among the 4 infections that the Safe Start Plus project is addressing, hepatitis B stands out as particularly critical. In addition to maternal screening and treatment, timely hepatitis B birth dose vaccination administered within those first hours of life is up to 95% effective at preventing chronic Hep B infection. Yet we know that in many high-burden countries, coverage remains far too low, and this is due to gaps in supply and cold chain capacity and healthcare worker training, as well as the ability to reach babies born outside health facilities. So as part of Unitaid's broader work on EVT, we partnered with Gavi and PATH to advance access to hepatitis B birth dose under the Safe Start Plus initiative. And today we'll hear some of the early evidence and insights from this collaboration. So just to close, I want to emphasize that Unitaid remains deeply committed to this initiative and that it exemplifies so many strategic priorities for us as an organization around country and community leadership, the focus on integration and service delivery resilience, and across maternal and newborn health product access. And we see that by combining Unitaid's catalytic and innovation-driven approach with PATH's deep technical expertise and Gavi's long-term financing and country support, we're truly creating a pathway for sustainable adoption of birth dose going forward within integrated elimination programming. And today we're excited to hear these early results and insights from the team, and we're also proud to continue to partner with PATH and Gavi and others in this area. So with that, I'll hand it back over to you, Albert.
Yeah, so thank you very much, Kelsey. We truly thank Unitaid for the partnership, the countries that we're implementing this project together with the community, implementing these catalytic innovative interventions, really aiming at accelerating the progress. So with that, I would like to now invite the second speaker to provide remarks. I hope Dr. Steve Sosler, you've joined. So Dr. Steve is the head of vaccine programs, First Year Live platform Gavi, the Vaccine Alliance, and he shall be walking us through the global progress on scaling the Hep B birth dose vaccine. The stage is yours, Dr. Steve.
Thank you, Albert, and thanks, Kelsey, and good afternoon, good evening, maybe good morning also to some. Just to thank everyone for, everyone who's been involved in pulling this session together and as well for the opportunity to speak to you today with some framing remarks, I would say, ahead of the dynamic session that we have before us. My name is Stephen Sosler. I'm head of vaccine programs at the Gavi Secretariat. I'm focusing on our first year of life supported vaccines. This includes hepatitis B birth dose, as well as how hepatitis B is also provided through other vaccines. So our pentavalent and more recently hexavalent vaccines. With respect to hepatitis B birth dose, globally, we know that birth dose adoption has expanded and coverage has increased over the past decade. More countries now have hepatitis B birth dose in place as part of their routine schedules. And globally, we have seen incremental gains in timely coverage. That's globally. The story, of course, in Africa is more complex. In many African countries, while third dose hepatitis B coverage through delivery of the primary series through pentavalent vaccine is relatively strong, we continue to see timely hepatitis B birth dose coverage lags. And this often lags significantly behind. And as we know, not all countries are ready or in a position to introduce this high impact, high value for money vaccine. Moreover, it's necessary to note that countries are considering whether to introduce hepatitis B birth dose in a very different financing environment than even a few years ago. Governments, as we know, continue to balance many other competing priorities. Some of these are related to new vaccine introduction opportunities, such as HPV, malaria, typhoid. The list is actually quite long here. And there are other priorities, of course, beyond immunization, beyond primary health care, even beyond health interventions that countries are considering. All of this is occurring in the context of even more constrained domestic fiscal space and evolving donor support, including reductions and changes in the Gavi financing model. Against this sort of, I would say, sobering backdrop, introducing hepatitis B birth dose is not always the easiest policy decision. And even once introduced, the importance and urgency of vaccinating newborns as early as possible, hopefully within the 24 hours that's recommended, presents very real operational challenges, as Kelsey has already noted, and as I'm sure we're going to hear shortly from country colleagues on these challenges and how they try to overcome them. What this means is that the challenges we're faced with are twofold, right? I mean, first, there's making policy decisions to introduce the vaccine. And second, there's the translation of this into consistent, timely delivery across diverse health system realities under constrained resources. In both instances, there's ample and strong country experience, which we'll hear from today. And this experience really helps to allow other countries to leverage and translate into their own context, as well as for how we as partners who are on the call today, can be supportive of country-led actions. So it's pretty clear that supporting introduction decisions in the context of funding constraints and difficult trade-offs remains foundational to moving this program forward. Without the policy decision, however, there really is no platform for scale. So without countries making the decision in the circumstances of limited resources to introduce the vaccine, taking the program to scale isn't even on the table. As programs mature, success will then depend on whether introductions are designed for timely delivery and sustainability from the outset. What we know empirically is that strong programmatic performance and sustainability depend on a number of factors, including, of course, but not limited to deep integration between EPI and MNCH, delivery room vaccination protocols, that clear handoff between maternity and immunization teams, facility level tracking of births versus vaccination to monitor progress. And this is precisely where the experiences of the 4 countries that we'll hear from today become so instructive, because they reflect similar but also very different system realities. And these realities translate into both opportunities and constraints for which innovation is going to be key to help try to overcome. So I'm very much looking forward to hearing from our speakers today, who represent long-standing implementers, as well as more recent introducers, both of whom are grappling with their own programmatic and system design questions. So with that, Dr. Komba, I'm going to turn it back to you. And again, look forward to an engaging next couple of hours to hear from the different speakers.
Thank you very much, Dr. Steve. Thank you so much. We appreciate it. So now next we're going to switch gears a little bit. So prior to starting the expert panel, I will be inviting my colleague who's going to be talking about Hep B birth dose learning agenda, the insights from the cross-country synthesis. Next slide, please. And this is none but my colleague whom we're working together at PATH. I might not have mentioned I work with PATH. This is Dr. Catherine Shirley. She's the Deputy Director, Primary Healthcare at PATH. Catherine will have two roles. She's going to present, and then later on she will invite Dr. Simba for the panel. So back to you, Dr. Catherine.
Thanks so much, Albert. It's wonderful to be here today. I'm delighted to be presenting the synthesis results from across our consortium. I really want to first thank all the people that have been involved in this project over the last year, from the communities that we've engaged with, the healthcare workers, the administrators, and health system leaders for sharing their insights, as well as our extensive team across the 4 countries who have been working hard on this learning agenda, and we're really excited to be sharing the insights today. Also want to thank our steering committee for their expert insights over the course of the last year as well, and of course Gavi for their funding support and Unitaid and partnership. Thank you. Next slide. So the birth dose has been recommended by the World Health Organization for hepatitis B since 2009. However, many countries have yet to introduce it, or introduction has only recently happened. But in places where it has been introduced, there's still been a challenge of meeting the recommended guidelines to administer it within 24 hours of birth for the greatest effectiveness. And in many African countries, the challenge is still that there are high rates of home birth in many regions. And so how do you get the birth dose to those babies who may be born in out-of-facility settings? So this learning agenda came together really around an objective of exploring innovative service delivery strategies and assessing the role of the community health system and understanding broadly what are the stakeholder perspectives on different models or promising models that could increase birth dose coverage, and then critically to disseminate that evidence to countries who have already introduced the birth dose and are looking to increase timeliness of coverage, and those that are new to introducing it. The themes that this work has really focused on include the understanding the context, barriers, and facilitators to birth dose access and delivery. What are the operational feasibility considerations related to controlled temperature chain and various product presentations that could be used? We also looked at market questions, demand forecasting for the vaccine, and others. And so it's been a very broad learning agenda. Today we'll be focusing on some cross-country synthesis insights, and really excited to hear from our panel of experts on taking this work and insights forward. Next slide. So these 4 countries represent a diversity of contexts, and they were selected because of in the Gambia and Nigeria, they are models of introducing this birth dose for over 25 years, and they have a lot of experience to share. And then in Ethiopia and Uganda, they more recently launched the birth dose. Hepatitis B prevalence ranges from 2 to 6 or 7% in these countries, although in particular regions of each country that prevalence is much higher. And birth dose coverage, while relatively high in Nigeria and the Gambia, they are still trying to move the needle on timeliness of that within 24-hour recommended guideline. Home birth rates vary across these 4 countries, as high as 50 or 60% in some places. And again, in pockets of these countries, it can be much higher. So there is a real challenge in reaching infants born outside of facility settings or born at home. And each of these countries has various strategies for how they're implementing the hepatitis B birth dose. Some really the primary focus is facility-based administration. There is some outreach and planning for outreach happening. And each of these countries also has different community health system contexts. In some countries, like in Ethiopia, the health extension worker is scoped to provide vaccinations, although home delivery of this particular vaccination is not part of the current strategy. And we'll be talking a little bit more about insights on promising models there. Next slide. So in terms of methods for the learning agenda, this really was a mixed methods implementation research approach that started with a literature review of understanding the global context for out-of-facility immunization delivery strategies, and then included desk review of country-specific literature and policy documents. That was followed by primary data collection through interviews and focus groups in all 4 countries. And you can see on the right here, each country had both a national focus of interviewing leaders in country working on immunization, as well as maternal and child health experts. And then subnationally, where we connected with health system leaders, nurses, midwives, and communities themselves, including caregivers. And this really framed our understanding of what the key barriers and facilitators were. And in 2 of the countries, Ethiopia and Uganda, contributed to undertaking human-centered design workshops in those areas to really co-design prototypes or implementation strategies to address how to increase birth dose coverage and particularly timely coverage, and really how to reach those infants who are born in out-of-facility settings. Underscoring all of this was market research and analysis on both the product presentation, particularly a single dose versus a multi-dose 10-dose vial, and also looking at controlled temperature chain as part of the overall operational feasibility consideration for how do you do outreach or home-based vaccination in very remote areas. And we were also looking at the cost modeling projections for a 1-dose versus a 10-dose vial. Next slide. We used an overall analytical framework to organize all of the findings. This framework is adapted from UNICEF from their Journey to Health and Immunization framework. And so we've organized the findings presented today around critical aspects of knowledge, awareness, and belief, intent, preparation, cost, and effort, experience of care at the point of service, and then after service follow-up. Recognizing that these areas are multifaceted. There's a lot from the caregiver and the health worker perspective that goes into the actual point of service, and there are different interventions that can happen across this continuum. And so we wanted to organize both the findings and the implementation strategies to address the unique barriers in each of the countries. Next slide. So I'm going to go through a set of facilitators and barriers that we've synthesized across all 4 countries. We will be sharing the links to the full reports so you can dive into full case studies for each of the 4 countries. And this is really more of a high-level synthesis of what's emerging across the 4 countries. Next slide. So in terms of knowledge, awareness, belief, and intent, there are facilitators related to trust within the community and with the community health cadres, as well as acceptance, a strong network of community providers who serve as a trusted source of information, and community support that contributes to accessing facility deliveries and referrals. But then in terms of barriers, many people and communities cited just overall limited caregiver knowledge, some cultural and religious norms, and hesitancy over newly introduced vaccines. So this can contribute to delays in care seeking. There's overall irregular training, and in a lot of countries, a dependence on limited EPI staff who may or may not be available at the time of birth in the facilities. And in many places, there are cultural practices that favor home-based birth, and contribute to low uptake of the birth dose, or at least also contribute to delays in accessing the birth dose. Next slide. In terms of preparation, cost, and effort, the facilitators were really that the ability to leverage the community structures, like time and again, community structure in each of these health systems is critical for engaging pregnant women and families and providing knowledge on and working together on a birth plan, promoting birth dose vaccines in general. But the barriers include overall high transport costs, long distances to get to the facility, road travel concerns, safety concerns, and really an unreliable ambulance system, particularly reaching women needing to deliver who are in very remote regions. Also, a weak cold chain capacity and unreliable electricity are challenges for vaccine availability at the health facility. And that can contribute to timeliness as well. Informal and inconsistently defined community-based birth tracking systems are a challenge in areas that have a lot of out-of-facility births. And so a lot of coordination challenges there. And then community health workers lacking training and in some cases, just general knowledge challenges with getting the information out to community health workers about this birth dose and ensuring that that's part of their curriculum and what they're trained on. Next slide. For experience of care at the point of service, for facilitators, we found that adequate training and access, both for nurses and midwives who are willing and able to administer the birth dose, is a facilitator, and as well support from community health workers and family members to prioritize accessing required vaccines for newborns, and then finally respectful and supportive interactions with healthcare workers that encourage the birth dose and the timely access to the birth dose. But for barriers, there are a number of cross-cutting challenges across the countries, including staff shortages, stockouts, restricted service hours that contribute to lower access to vaccination. And there was also the issue of some fears around wastage from multi-dose vials. Many countries are using a 10-dose multi-dose vial for hepatitis B birth dose. There's also the challenge of accessing the birth dose immediately after birth. If you give birth at home, there are other priorities around wellness and also, reduce. This may not be the highest priority to get to the facility immediately. And there's also issues related to fear of judgment or communication and negative interactions that caregivers shared around their interactions with providers, being reprimanded for giving birth at home and not receiving a timely vaccination. So finally, high workloads, limited staffing, reliance on dedicated vaccinators was also cited as a challenge. These are some general human resources for health challenges that we see and not unique to this particular birth dose, but nevertheless an area that is a barrier. Next slide. Finally, for after service follow-up, the facilitators are related to digitized registers that a number of countries are introducing for structured immunization tracking systems that can help both support the birth dose, the identification of home births, but also follow-up and support tracking of who still needs the birth dose. The barriers relate to overall delayed recording of home births and the tracking of those home births, some lack of coordination to be able to track those and communicate. The need for the birth dose also contributes to delays. Some of the countries in this group, in the private facilities, they're not consistently reporting vaccinations or providing birth dose vaccinations. So there are gaps there, and then poor communication from health providers about which vaccines need to be given is another barrier. Next slide. I want to next just highlight some of the unique promising models that emerged to the human-centered design process. Again, this was undertaken in 2 of the 4 countries, Ethiopia and Uganda, and really involved coming together over a 4-day workshop at the subnational level to bring together caregivers, including mothers, fathers, grandmothers, as well as community health workers, facility-based providers, and health system administrators to really talk through all of these barriers and facilitators and come together and co-design innovative strategies that could help address some of those barriers. There were a lot of implementation strategies that were put forward and prioritized. We won't have time to get through all of them today, but as I mentioned, we'll be sharing the resources in the chat where there's more information on each of these strategies can be found. Next slide. So first I want to highlight some of the community level implementation strategies in Ethiopia. And this was really a 2-track strategy. So there are areas of the country with very high levels of home birth rates, close to 70%. And so one of the strategies that emerged strongly there was that actually administering the birth dose at a health facility after home birth, and that requires close coordination with the health extension workers, including notifying facilities of the home delivery and helping to arrange transport from really remote areas. So this is going to require support and greater coordination around ambulance transport, as well as the close coordination on birth tracking and supportive strategies around partner engagement and demand generation and other communication around to dispel some traditional beliefs around the vaccine. And this can be coupled with another strategy that is reaching infants in their home. So really leveraging the strong health extension worker platform to deliver the vaccine at home through an integrated postnatal care approach. So this really would be much stronger collaboration across EPI and MNCH and leveraging that health extension worker to vaccinate. It would require some additional support around transport to ensure that health extension workers can get to the remote areas where home births are occurring, and also requires some cross-cutting strategies around, similar to the other strategy around engaging men, debunking traditional beliefs, and ensuring the consistent supply chain that the health extension worker could use for home-based vaccination. We'll hear more from our colleague in Ethiopia about reactions to this strategy, how it might be taken up in the future, but it's definitely a novel strategy for reaching particularly out-of-facility births. Next slide. Just a quick overview of this slide. This is just showing the same content I just voiced over. You can find this in the resources we'll share, but just to say, there really is 2 strategies that can reach infants that are born in out-of-facility settings. One where it's really focused on going to the home to vaccinate, and the other is much more about connecting recently delivered moms who've recently delivered with the health system with some transportation support. Next slide. So in terms of community level implementation strategy in Uganda, the home-based vaccination strategy did not emerge as a priority. Rather, there was much more focus on strengthening overall community sensitization, paired with respectful and consistent ANC counseling. So on the left here, a priority strategy is this really wraparound sensitization on the importance of birth dose vaccines, how it contributes to preventing mother-to-child transmission, and knowledge around importance of facility delivery and how to prepare for transportation and costs. This also included very clear messaging delivered by village health teams and community health extension workers, influencers, and through other channels like community gatherings. Similar to Ethiopia, saw a strong role for engaging men and families and the support and decision-making around accessing facility delivery and birth dose. And then the role of the ANC platform as a channel for respectful communication and knowledge and awareness raising among pregnant women. And then also importantly, a message around reinforcing that newborns should not be turned away if they're not meeting that 24-hour window. They can still be vaccinated up to 6 weeks. Second, community level priority strategy in Uganda was around strengthening trust, coordination, referral, and linkages with facilities. So this is really leveraging strong village health team presence for respectful communication about the birth dose vaccine, its safety and value. And then working in close collaboration with traditional birth attendants on the notification around home birth tracking and alerting facilities when and where home births are happening so that the village health team and CHOOS can follow up and help refer and get the mother baby pair to the facility for administration of that vaccine. Other kind of supportive strategies as part of this are ensuring that the community health worker contact information is recorded on ANC and immunization cards to help women contact their local community health workers for real-time follow-up. Coordinated messaging across the community health network and facilities so that there's consistent guidance and supportive care for mothers, and then cross-checking with the community providers to verify that those newborns that have delivered at home actually have subsequently received the birth dose. So in general, this strategy is really a lot about coordination and linkage to the facility. Next slide. For facility level implementation strategies, comparing some of the strategies that emerged in Ethiopia and Uganda. So both are critical. In Ethiopia, the emerging insights were really around strengthening the facility readiness to vaccinate immediately post-delivery. So this requires vaccine availability in the maternity ward and regular resupply so that it's there at the point of birth. It also relatedly requires expanding the capacity of nurses and midwives to deliver the birth dose shortly after birth, which has a whole kind of component around training, documentation, and safe vaccine handling, and then improved coordination and data flow across the delivery and EPI teams so that they're coordinated and following up on timely administration. In Uganda, there's some similar themes that are emerging around the coordination across maternity and EPI teams. And really in Uganda, it was around positioning this as shared responsibility across these teams and ensuring 24/7 vaccine access, storing the vaccine in or near the maternity wards for ease of access. Similarly to Ethiopia, there is a component of capacity building for midwives to ensure training and mentorship on administering the birth dose. And then, establishing some sort of checklist so that there's no discharge without vaccination. This relates to workflow, clarity of workflow, monitoring, and then lastly, streamlining the data systems so that the registers are aligned across maternity and EPI, and tracking the timeliness of the birth doses is another priority as well. Next slide. I want to shift over to some of the operational feasibility data related to the product presentation and supply chain. Next slide. So when we looked at some cost modeling for 1 dose versus 10 dose vial, we found a really strong preference among country stakeholders for the 1 dose vial. Really part of that is around its relevance for reaching out of facility births through outreach or at the home, or other strategies. So respondents noted that the one-dose vial is important for reducing wastage, increasing acceptance, and reducing missed opportunities for vaccination due to low client volumes. So I alluded to this earlier, but in some places there are fears around opening a multi-dose vial and then not being able to use it immediately with other infants that need that birth dose. So this modeling was done in Ethiopia and Uganda and found that the one-dose vial had better value for money in a home-based delivery setting. This was driven by lower wastage rates, whereas in facility-based delivery, the product, the 1 dose versus 10 dose, really depends on how many births are happening in that facility over the month. So if you have fewer than 5 births, the 1 dose vial would offer better value for money, but in higher facility volumes, more than 5 births per month, the 10 dose vial is better value for money. Next slide. We also wanted to share some perspectives on controlled temperature chain qualification for hepatitis B birth dose, or CTC. So CTC is an approach that allows certain vaccines to be stored outside of the cold chain for a limited time under monitored temperature conditions. Respondents were enthusiastic about using a CTC qualified hepatitis B birth dose to address some of the operational challenges. About half of the respondents, however, were not willing to pay more. I think there is a lot of excitement around the anticipated benefits of the CTC qualified product and how that could further enable some of the outreach strategies to reach babies who are born outside of facilities. It could really contribute to increased coverage and increased timeliness. But there are also some risks and challenges that respondents cited. There's the need for policy change to then allow for the CTC product use for hepatitis B birth dose, the need for additional supplies, and for monitoring temperature exposure, additional training requirements to upskill healthcare workers, potentially some issues of confusion as well. I'm going to go to the next slide. I think we have a long list of recommendations at both the global and country level, but in the interest of time, I'm going to just highlight a few so that we can get to the country panel shortly. So at the global level, the need to continually update the demand forecast to inform the global supply needs, support on streamlining the WHO CTC qualification process that will encourage manufacturers to pursue the CTC approval, and then Gavi support for expanding procurement to allow for the single dose procurement product, and then creating channels for decision makers, implementers, and others to learn about new insights on increasing coverage of Hep B birth dose. Next slide. Some of the just one slide. Thanks. Some of the emerging recommendations for country stakeholders really relate to some of the readiness needs, health system strengthening around immunization functions to enable effective birth dose delivery, developing policies to embed and better link EPI and maternity care and really taking a more integrated approach, considering multiple vaccine presentations. So there may be reason to use different presentations for different delivery contexts, and then further local adaptation of delivery strategies. And the human-centered design process can support that. Next slide. There's a number of potential recommendations countries could take forward, leveraging their community health worker platform. And that relates to some of the data we shared on linkages between communities and facilities, the potential to expand the community health worker scope of work to vaccinate in the home or outreach settings, and then monitoring overall timely administration of the birth dose. as many countries are focused on overall coverage, but not necessarily measure time use. Next slide. I'm going to skip this slide in the interest of time, but we do, in the reports we'll share, we do summarize some of the implementation research gaps and priorities for the global community. So it's my pleasure to now introduce our expert, our moderator for our expert panel. Dr. Simbarashi Mabaya is a senior program manager at Gavi, the Vaccine Alliance. He's based in Geneva. He is leading Gavi's program for supporting low-income countries to deliver the hepatitis B birth dose vaccine, and has extensive experience working as a clinician and a public health expert across immunization, HIV, viral hepatitis, and primary health care. With that, over to you, Simba.
Thanks very much, Kate, and hello, everyone. So I'm going to help you through a panel with 7 experts. So we have first Dr. Mbanjai from the Deputy Program Manager for EPI from the Gambia. We have Dr. Rufai Gaba, the Director of Disease Control and Immunization from the National Primary Healthcare Development Agency in Nigeria. Dr. Mohamed Bello, the Head of Division, Health Services, National Primary Healthcare Development Agency in Nigeria. We have Sister Doreen Ruth Akuno, who is a Senior Nursing Officer and focal point for hepatitis in EPI in the Ministry of Health in Uganda. We have Ioannis Lakel, who is a Senior Advisor for Immunization Services at the Ministry of Health in Ethiopia. And we have Prince Okinedo from Nigeria, also the founder of the Hepatitis Advocacy Foundation. And lastly, Professor Ponziano Ochama, who is an associate professor from the University of Makerere College of Health Sciences in Uganda. So I will jump right into the first question. The first question to you, Mbanjai, on Gambia. So we know that the Gambia is a relatively low rate of home deliveries, about 13%, quite low compared to some of the African countries. And you have achieved a high overall coverage of the birth dose, over 80% over the last few years. However, in this 80%, about 37% are those who are vaccinated within the first 24 hours, which is the recommended timeline for maximum effectiveness of the vaccine. So building on the learning agenda, the insights from this learning agenda, and how is your program going to approach this last mile of timeliness? So to get all that more than 80% of children who are getting this vaccine, to get it within the first 24 hours, so within the health facilities. So we are thinking particularly around maternity ward workflows and ensuring that no newborn is discharged from the facility without getting the vaccine. Over to you, Mbai.
Thank you very much, Sumana. Good afternoon, good morning, and good evening, everybody. Thanks for the question. For the Gambia, in trying to approach the last mile of timeliness within 24 hours, there have been a lot of improvements or strategies that are in place. The first thing is about the policy issue. The Director of Health Services have definitely written to all health facilities to ensure that no child is discharged from a newborn is discharged from the health facility without being vaccinated. But this is something that needs to be supported with certain strategies, like ensuring that the vaccine and the vaccinators are available during childbirth. And then the strategy that is in place is ensuring that health workers, just to give a background, Gambia, immunization is given by public health officers who are different from midwives. But here, what we're trying to do is ensuring that public health officers are available during vaccination during after delivery. Some health facilities have definitely started having health workers on shifts who are responsible of vaccination, both morning, afternoon, and night shifts, to ensure that like any child that is delivered during these periods are given vaccinations before they discharge. And also like training of midwives and also health workers to ensure that like they understand the importance of timely hepatitis B vaccination. And this has definitely been conducted throughout last year to ensure that like health workers are definitely trained. Ensuring also like some health facilities do not have cold chain system. And then the expansion strategy is ongoing through the CCOB cold chain equipment optimization platform. There has been series of expansions. Just recently, as we speak, there is an ongoing installation of new equipment to health facilities that have been identified to be offering immunization services. And also the Directorate of Public Health Services, who is also to support the afternoon and morning shift, and also anytime the vaccinators are available. The Directorate of Public Health Services ensuring that health workers are also posted to facilities and they work on shifts. This is definitely ongoing. And last year, we also introduced weekend vaccinations. Weekend, like, because during morning, afternoon, night, during the weekdays, but after weekends also are very, very important. And then health workers are also now working during weekends to ensure that like children are being vaccinated. But also the other issue is like the other strategy is working with the National Health Insurance Agency. They have included the BAT doses as part of the RBF package, whereby indicator packages, whereby they'll be bought by in health facilities where they are operating, and this was definitely going to improve because any child that is vaccinated, given the BAT doses, is monetary value to the health facility, and they will definitely be increasing the coverage. The other aspect is like this year we are also trying to introduce working with UNICEF. We are having UN volunteers that will be working at community level, and part of their TOR would be to ensure that like they reduce zero dose and under immunized children, and as an activity they will be promoting and encouraging pregnant women to deliver at home, and also ensure that like children that are also delivered encourage mothers and to deliver in health facilities, and ensure that children that are delivered at home, they definitely quickly get them vaccinated within 24 hours, get to the hospital and then go clinics to be vaccinated. So these are among strategies that we are definitely doing to ensure that like the last mile is definitely achieved to these routine services.
And thanks very much, Banjai. I think this is quite comprehensive and interesting to see all these deliberate efforts being underway in the Gambia to increase the coverage for timely birth dose delivery. I will go to Dr. Mohamed Bello now. No, I think Dr. Rufai Gaba first. Then if we have time, I'll come back to you, Banjai, for any additional question.
Okay, thank you.
So, Dr. Gaba, so Nigeria is both the facility-based and outreach delivery strategies, and community healthcare workers are authorized to administer vaccines. Yet we see that the coverage of the timely birth dose remains at 17%. Against a coverage of 58% of all children who are getting the birth dose, including those that are getting it outside the 24-hour period. So what do you see as the most critical bottleneck that's preventing this timely administration? And how are you using the insights from the learning agenda to help address some of these challenges? Over to you, Dr. Gaba. Is Dr. Gaba still on? I don't seem to see him, so maybe we can go to Dr. Mohamed Bello, and when Dr. Gaba rejoins, so we can go to his question. So Dr. Mohamed Bello, the learning agenda has identified integrated postnatal care as one of the most promising platforms for reaching children with the hepatitis B birth dose vaccine, particularly for home births, where the postnatal visit may actually be the first structured contact with the health system. So in the primary care system, the context in Nigeria, how realistic is it to consistently bundle the birth dose vaccination with early postnatal services? And what would need to change in terms of staffing, in terms of protocols, in terms of the workflows, to make this a norm rather than an exception? Over to you, Dr. Bello.
Thank you. Good afternoon, everyone, and thank you for having me. I think my assessment based on what obtains in Nigeria is to say that bundling hepatitis B first dose with postnatal care is very realistic in the country because we have all the regulations and policies. What remains to be emphasized is the operationalization. However, I must admit there will be some average obstacles in rural and low burden load. It is more practical in facilities in the urban, very urban, and then high volume facilities where this and then the human resources are more. But even in the rural facilities, we can actually restructure the flow and the staffing protocol to make it happen. Now, if you look at what obtains, I think the major constraints that limits the possibility of bundling hepatitis B at the best dose is to say that, one, we treat these services as silos. So the maternity is treated as a different service, and then the API for the routine immunization. Hardly do they even come there in separate building, even in the same facility, different staff. Now, when we are dealing with PHC, what needs to change is to ensure each and every skilled birth attendant is trained to be able to provide immunization. And then we cross-train the CHUs and J2s to be able to provide this immunization at birth whenever they deliver a lady. Secondly, is to ensure that we have mini cold chain in the maternity. So we have we have trained and make the skilled birth attendant capable of administering the vaccine, and then we create a mini cold chain that we have the antigen available in the maternity home. This will help us, will go a long way in seeing that we treat the mother and the child as a pair, not as separate entities because of the integration of the RAMCA. Secondly or thirdly, what we should do is to for the documentation, because we have a procedure for what obtains in the maternity home or the maternity ward, and then the procedure for discharge. So if we put as a check that a child has to be vaccinated for the 3 antigens, BCG, OPB0, and hepatitis, before this is discharged as part of the procedure, then this will make sure that any person, the healthcare worker that is there, will ensure as a checklist, as a requirement, instead of leaving it as an option at the discretion of the healthcare worker. It is part of the procedures, part of the protocol. We do these 3 things, it will strengthen birth dose of hepatitis. We also have to integrate the MIE component. We have separate registered kept at different places. So we treat them as different entities. We either do 2 things. We can actually have a register for the first 6 weeks, tracking the services provided for the mother and the child. This will remind any provider that I'm dealing with two individuals that need to get these services. Any condition for the mother and for the child. So it is essential that we also revise this so that the documentation. The fourth that we can change and make it a norm is to ensure that we have as our protocol that a woman has to be kept in observation for some hours after delivery before discharge. This is not implemented to the latter in most places. So the linkage between delivery to postnatal care, at least that 24-hour wait, and then we ensure that postnatal care is conducted on every, at least for the mother and child for the first 24 hours daily in these facilities, and the providers are able to do this. Now we have the Care Provision Fund, which is a financial incentive to facilities to make them more capable of providing the services and then incentivizing them for improved quality and service delivery. If we incentivize as part of the indicators for the disbursement of these funds, incentivize the facilities to ensure that first dose of these vaccines are given as part of indicators that we check for the disbursement. I think if you incentivize, the behavior will also follow suit. So we do all these form of changes, form of procedures and protocol, and ensure that during supervision and monitoring and evaluation, we look at these indicators as integrated. We do not split. That maternity home will look at indicators for deliveries and others, and then API will look at indicators for child. So we integrate the indicators, and then during monitoring, supervision, and review meetings, we check for this and ensure that we ask for this one, and then for the finances, we ensure we incentivize facility that does that. One of the major shifts in the version 2 of Basic Care Provision Fund is to ensure that we tie performance to disbursement of funds to facilities. So facilities of the same level might get different amount of money depending on the output of their work and then adherence to protocols. So if we make sure we integrate this service as a procedure, and then adherence to this procedure is one of the checks we look to ensure that a facility get additional resources in the direct facility funding, it will go a long way in ensuring that we integrate the services and there is a greater uptake for childbirth, for deliveries that occur at the facilities, that the newborns get the first dose of hepatitis and other antigens. So we do this, I think, and it is something that is very, very possible with the resources. One good thing about this is that this is an immediate thing we can do. We do not need additional infrastructure, physical infrastructure. We may not even need to recruit more people. It's just to change the shifts and ensure that everything that is done in an integrated and more efficient way to ensure that both the mother and the baby get what is expected of them as per the national protocol.
Thank you very much, Dr. Bello, for those reflections. I will now transition to Sister Doreen. Sister Doreen, I will ask you to try to be as concise as possible in the interest of our time. So my question to you is that Uganda's implementation strategy is focused on administering the birth dose within health facilities. But given that the village health teams and the community health extension workers are already playing a critical coordination role, what would it take in terms of policies and operationally to expand the community healthcare workers' role to include the administration of the birth dose, especially in those districts where there is quite a high rate of deliveries within homes? So over to you, Sister Doreen.
Can you hear me?
Yes, sure. Go ahead.
Okay. Thank you so much. We agree to that, and part of our first policy is we have put in place the political and policy approval for the Ministry of Health, and this include the formal task shifting authorization and professional council alignment in every implementation that we put in, and especially in the new implementation, like the new introduction of the hepatitis birth dose. Secondly, structured training and supervision, ensuring that all the levels of implementing teams at service delivery are brought on board, talking about the health workers, the VHTs, the CHIOs are really certified to see that this is done so well. And we give them the quality training, like in safe injection practices, cold chain handling. We also look at documentations and waste management. Maybe thirdly, we also look at sustainability and logistics handling. But this reliably include the last mile delivery of vaccines up to the hard to reach areas. And then we are so much supporting the integration and integration of all the service delivery points without leaving out vaccination. And we focus so much when it comes to prevention. The government of Uganda is really trying the best to see that, their level best to see that prevention is the key. Prevention is where we are aiding under primary health care. So vaccination under prevention is what we are so much focusing on. And so we see that this comes as one of the policies that has been endorsed. We also look at the community platform. We are not leaving them out under policy. We are working with the community, because the key shift would be policy, endorsement, and then the resourcing that is under Uganda, where we don't have fundings from supporting implementing partners. We have domestic funding that really support us. And then we no matter how much we are spending, we are also looking at the strong accountability system that really supports our activities across these implementations. So under policy, basically, those are the few things we are looking at. Thank you.
Thank you very much, Sister Doreen. I'll go to Johannes from Ethiopia. Johannes, Ethiopia has launched the hepatitis B birth dose vaccine with Gavi support in November of 2025. So this is an important moment to take stock. So from your reflections of the implementation so far, what has been the successes, and where are some of the most significant gaps that Ethiopia is working to address to increase the timeliness of the hepatitis vaccine? Over to you, Johannes.
Yeah, thank you very much, colleagues. It's a pleasure to be here in this panel. Am I audible, right? Yeah, great.
Yes.
As you have rightly mentioned, Ethiopia has introduced hepatitis birth dose vaccine very recently, just 3 months ago. Even though the country wished to have, the vaccine many years ago before, because of the low health facility delivery, we couldn't introduce, the hepatitis birth dose vaccine for our kids. As Catherine also showed, in the prevalence of hepatitis B virus is very high in our case. There are regions which have, accounts up to 14% of, the virus prevalence. And at the pregnant mother level, even the prevalence is too much high, it's up to 5%. So we have a big prevalence in terms of hepatitis, and the vaccine is very important for us. So following a pilot study for 3 years, started from year 2021 up to 2023, we try to see how the hepatitis birth dose vaccination will be feasible in our case. And the pilot findings shows that, almost more than 90% of newborns who are delivered at the health facility got the vaccine timely, and a few out of facility deliveries will get the vaccine. So the pilot's finding has clearly indicated that timely vaccination is possible for newborns who are delivered at the facility level. But the big question mark was raised during the pilot was reaching the out of health facility deliveries. So taking these two findings, the ministry has developed an introduction plan for 2 years and preparing a guideline how to address those kids who are out of facility and newborns who are at the health facilities. With this into consideration, the ministry has introduced the birth dose in November 2025, and since then, we have been trying to look at how many facilities are really started the vaccination of birth dose, and we were following for the last 2 or 3 months, to see all health facilities to start, the vaccination of this birth dose. So, based on the data that we have from the report, almost all the health centers and hospitals who have facility delivery has started providing the hepatitis birth dose. This is one of a success for our case because since our launching was very short. In addition to this, we have tried to conduct a training by including health workers at the maternity level, at the newborn care, at the API API focals were trained on this hepatitis birth dose vaccine provision, so that there is a task sharing activity among different departments in the health facility. So within these 3 months, our success, I can say we managed to vaccinate more than 320,000 newborns were able to get hepatitis birth dose, even though our targets are very high, but we managed to reach about 30% of newborns according to our plan. So looking at the performance, it is very low even compared to the facility deliveries. So there are many things we need to do in the future. One will be we need to make sure that missed opportunity should not be there in the health facility. So this is something that we identified with a very quick review of our data of the last 3 months. And the second one is we need to find a way to reach out of health facility delivery newborns to get the hepatitis birth dose timely. So there are strategies that is indicated in the national guideline. We have already included outreach vaccination whenever possible. Whenever we get a chance to vaccinate those kids within the 14 days, as well as within 24 hours, we'll try to include and vaccinate kids in outreach sessions as well if it is possible. In addition to this, a very strong social mobilization and the linkage will be one of the things that is proposed in the guideline, and that is the one that the ministry is currently doing. So in the future, probably the ministry is trying to look several, feasible, if it is feasible. There are, recommendations from the learning agenda of PATH to be piloted and tested. If it is cost effective and feasible, probably those interventions will be applied to reach newborns who are delivered out of health facilities. So in general, to summarize, our success is to introduce this vaccine, and we are glad that almost all health facilities are currently providing, and we identified that there is a missed opportunities still, even within the health facilities, and out of health facility coverage is very low, and we need to work on these gaps, and these are the points that I want to reflect, but it's a good opportunity for us, for the country team to learn from the others. So the webinar is, we thank for the organizers, and we got some lessons from our colleagues who spoke for me. Thank you. Over to you.
Thank you very much, Ioannis, for those reflections. I will quickly go to Prince. Prince, so we know that caregivers and community trust are foundational for timely birth dose vaccination. Yet we know that in Nigeria and also in a few other countries, vaccine hesitance around newly introduced products remain a real barrier. So as an advocate, how do you approach building public demand for the birth dose specifically? And what messages or messengers have proven to be most effective in Nigeria? I will ask you to be as concise as possible, Prince. Thanks.
Thank you very much for the opportunity to be on this panel. So I think just to be clear, that it's not much about the concern for demand. I think from what we have seen on the ground implementing projects, we have seen that it's much more about infrastructure and institutions and in terms of knowledge for healthcare workers. Now, we've had situations where mothers are turned back to come on immunization days for vaccination. So if we are not able to address the in-facility beds, it will be much more difficult to address beds outside facilities. Now, the situation where I haven't seen in the course of my activities, I haven't seen where any mother rejected vaccinating their child. I'm speaking from practical sense now. I haven't seen any. But what we constantly see is situations where the mothers present their children for vaccination, but they are not able to vaccinate. Why? Because the bed doses are centralized and then immunizations are done on scheduled days. I'm glad the National Primary Healthcare Development Agency people, directors are here on the call. So it is a big problem. There seems to be a disconnect. So it's not much about the demand, really, from the community aspect. Okay, it is about the institutions. It's about knowledge gap. How many of our healthcare workers understand that this bed dose must be delivered timely? So we did an assessment 2 years ago to look at the timely bed dose, and we found like 5.7% timely bed dose uptake. And now go to facility. Imagine a situation where facility conducts immunization just 1 day in a week. So how do you go back to the community and tell them bed dose is very important for your child? So once the child is born, present your child for the bed dose, and that woman presents the child on a Friday, where the bed immunizations are done only on Thursdays. What happens to the child? The mother will be sent back to return the following week when vaccination or immunization will be conducted. So that's a major problem. And that was one of the things we did with in terms of there was a project we implemented last year where we were looking at decentralization of the bed dose. That bed dose needs to get to the labor or delivery wards. And once we did that, every child born in those facilities, we piloted this, got the bed dose. So before the child left the delivery room, the child will be coming out with the bed dose. So if we're able to address that, then we can now substantially address out of facility beds. So I'm putting it squarely on the National Primary Healthcare Development Agency at the moment, because is a serious challenge, which I think this message hasn't trickled down from the national to the subnationals and even the local governments. And in situations where the bed doses are even, where, for instance, a child is born on an immunization day and the child or outside immunization day, the child gets the birth dose a week after. On the child immunization card, you see there's no provision for whether the birth dose was given within 24 hours or not. And that is captured as birth dose 0. And so that's, again, we need to look at the data reporting, which is very key. That's why we are not able we are struggling to say we have 17% timely, but I can assure you that that's high. So it's, for me, from experience on the ground, we are not looking at the demand from the community. Rather concentrate on institutions and capacity building, knowledge for healthcare providers. I think that's one way to go, and I believe the National Primary Care should look into that. Thank you very much.
Thank you for that, Prince. So I will ask Professor Ponciano Chama to come to the stage for this final question of this panel. So, Professor Ochama, the learning agenda calls for implementation research to clarify which strategies work for whom and why. And based on your research on hepatitis B in Uganda and the insights you have had today, what are the most urgent implementation research questions that remain unanswered and can have the greatest impact on increasing timely birth dose coverage in Uganda and across the African region? Over to you, Professor Ochama.
Thank you so much for these questions you've asked. And I think in the interest of time, I will be very brief. First of all, you know, Uganda chose to do the birth dose in health facilities. In order for this to happen, we need to develop clear communication. Communication worked very well for HIV, and they brought HIV where it is now. And we need to develop, therefore, clear communication on the importance of the vaccination and for the mothers to actually be able to go to the facilities. But yes, we can develop this, but one of the key things that we shall have to do once the communication is developed, then we have to study the effectiveness. You want to know if the mothers are actually taking up on what is happening. And then we also have to look at the pathways then. How do the mothers go to the facilities? We have said we are going to use we use the village health teams to do some of the things to enable these mothers go there. But how will these mothers go there? We need to study that pathway clearly. And also, once they reach the facilities, we need to understand the perceptions and the attitudes of healthcare providers. We have known that sometimes mothers actually say these healthcare workers are very rude to us. And that is one of the reasons why they decide to stay with the traditional birth attendants. And so we need to find out what happens there at the facilities. And once they are in the facility, we need also to look at the pathways for them within the facility itself. And recently we conducted a study. We screened 19,000 pregnant women from various hospitals, and we got 660 mothers who were positive. That was before the vaccination, the birth dose became national. We followed up these mothers, and at birth, all the babies got birth dose, but we were not able to track 44 mothers. So we don't know whether they did, because their phone contacts, they could not go through. So we don't know whether they delivered at home or in some other health facilities. We do not know. And so that kind of pathway within the facility should be studied. In that study that we conducted, the birth dose, the receipt of birth dose was in 97%, because we actually involved those hospitals and made sure that the vaccines were placed in the facility, in the maternity. And that is what made it possible for us. Even over the weekends, these babies got vaccinated. So thank you. I think those are the things that I thought I would bring out here.
Thank you very much, Professor Ochama. In the interest of time, I will hand back to Kath. Huge thank you to our panelists. Back to you, Kath.
Thank you to Simba for moderating and all of our panelists. This is great contact. There's so much so many questions in the chat and amazing comments about the importance of how the health system is set up and where women are able to access the vaccine for their babies. And so a lot. I wish we had time for a full Q&A, but we are getting to the end of our 90-minute session today. So, there's clearly demand for further discussion on this, and I look forward to more webinars and engagement across countries in the future. We wanted to share that we've just launched this project website with all of the resources you see here. So there's a synthesis brief with the cross-cutting findings across the 4 countries, a deeper dive on the human-centered design implementation strategies in Ethiopia and Uganda, as well as case studies and country policy briefs for each of the 4 countries. So I encourage you to check out the QR code on this website to explore these resources. Very briefly, I'm going to hand it back over to Dr. Stephen for some closing remarks and reflections. Thank you.
Yeah, thanks, Kath. I know that we're pretty much on time here. I think again, the richness of this discussion and looking at the questions that are in the Q&A and also in the chat, it really kind of begs for more time potentially to really be able to go into some depth here. But in closing, let me just reflect briefly on what we've heard today from Ethiopia, the Gambia, Nigeria, and Uganda, and what it might mean for where we go next. The central message, I think, is clear. Timely hepatitis B birth dose delivery cannot rely on facilities alone. It is something that needs to be looked at as a floor, but not necessarily as a ceiling, right? If we're honest, programs, if we're not able to, and I just heard it from one of the speakers, right? If we're not able to consistently vaccinate newborns on time within health facilities, then we're certainly going to struggle even more to reach those children, those newborns outside of them. So really strengthening timely vaccination facilities is, I guess we would form it as a foundation, right? But it's definitely not a ceiling. At the same time, in countries where a large share of births occur outside of facilities, enabling community health workers to provide injectable vaccinations becomes a core system design question. I know that some countries are limited by policy, but it does seem that potentially being able to expand the mandate of community health workers to be able to provide injectable immunizations is a powerful lever for improving equity and timeliness. Again, particularly when this is combined with other systems considerations related to strong birth identifications, simplified vaccination presentations, reliable last mile supply and logistics. I think what else was reinforced today is that there's no single model that works, right? But there are some common principles. So birth dose works best when it's embedded in maternity workflows. It's integrated really strongly. There's strong integration between MNCH and EPI and community systems. And it's designed for the particular context of the country. And I would even go beyond that and say the subnational context in which the program is operating. Again, looking for efficiency in design. And so ultimately, I think the question is, how we institutionalize the program so that from the outset, what we're doing is trying to make the program as operationally feasible, fiscally sustainable, and embedded in routine systems, thinking of that integration piece as strong as possible. Again, I probably missed a lot, But let me keep my remarks to that and turn it back to you, Dr. Komba, or to you, Kath. I'm not sure.
Thanks so much. Excellent remarks. It's a great wrap up, the high points and well summarized. Appreciate the closing remarks. We want to thank everyone for joining today. We will encourage you to explore the resources, get in touch if you have further questions, and we will also be sharing the recording and look forward to engaging on this topic in the future. Thanks everyone for your interest and for joining today. And special thanks to all the panelists.
Thank you.
Yes, thanks to all the panelists.